Good evening to all participants of the seventh year in review in breast cancer. At the outset, I would thank Dr. Shona Nag for inviting me to do a rapid review on this topic of HER2 positive breast cancer. Uh, I will be looking into these six abstracts for the rapid review and hopefully would give each one of them justice over the next 15 minutes. The first abstract is the analysis of study drug-related interstitial lung disease in patients with HER2-positive metastatic breast cancer who have been treated with TDM1. We know that TDM1 is approved for treatment of patients with HER2-positive MBC which have progressed on more than 2 lines of anti-HER2 therapies. This is the indication in the US, UK, and the EU, or after chemotherapy as what is indicated in Japan. Interstitial lung disease is being identified as an important risk for patients who are treated with TDX. And to further characterize the interstitial lung disease in these heavily pretreated metastatic HER2 positive breast cancer patients, the pooled data of the available phase 1, phase 2 breast cancer studies was evaluated. And in this pool data, there was an independent education committee which retrospectively reviewed all the potential ILD cases and the events educated as study related were reported. And there was a multivariate analysis done looking at exploring the association between these factors and the time to recurrence. So, based on these three studies, there were seen that the baseline characteristics, the median age was 56 years. They divided patients into those who were treated in Japan and versus non-Japan, and the performance status, and patients who had received at least 7 million prior regimens were the ones who were included. Across all the study population, the total incidence of drug-related interstitial lung disease was seen in about 15%, grade 1, grade 2 put together about 11%, and grade 5 in about 2%. Most of the patients had grade 1 or grade 2 events, which were seen in 30 out of those 38 patients, looking to a percentage of around 79%. What was interesting to see that the risk of all-grade interstitial lung disease decreased after 12 months as the cumulative probability of the adjuvant of the adjudicated drug-related ILD began to plateau at this point of time. The median time to first ILD event was about 5.6 months, as seen as per the cumulative probability curve. The assessment of factors based on this stepwise multivariate Cox regression model, there were only two which were identified: patients who were treated in Japan versus treated outside of Japan, and patients who had moderate to severe renal impairment at baseline versus no impairment. However, there are limitations of these analysis, mainly the small sample size and patients who have received extensive prior treatment. We should remember that these are patients where median lines of previous treatment is almost 7, and these risk factors need to be confirmed and they will further be evaluated in larger prospective data to look into the ILD. So they concluded that TDX is an very important drug in treating HER2 positive MBC. The early detection and optimal management of preventing high grade ILD is important. This has led to change in the guidelines for the ILD management for the drug. The risk of ILD also decreases over time, which suggests that there is no cumulative toxicity and we need more data. The second abstract is based on comparison of therapy benefit from standard anti-HER2 directed approaches in metastatic breast cancer between patients who were initially HER2 positive and those who were initially HER2 negative, which switched to HER2 positive at the time of progression. And these are registry data from the pregnant registry, and this is used to compare the outcome. There have been multiple meta-analyses which have demonstrated that about 5% of patients who are initially HER2 negative can turn to HER2 positive during the course of disease. The main objective was to investigate whether this baseline HER2 status of primary tumor had any prognostic value on the progression-free survival and overall survival, in addition to age, hormone receptor status, and in patients with metastasis who were treated with pertuzumab. Inclusion criteria were patients who were HER2 positive breast cancer with evidence of metastasis at the time of inclusion. Exclusion criteria where patients who were HER2 negative were unknown, and therapy with an investigational drug in a clinical study. Patients who received all types of therapies were eligible, and the analysis compared PFS for these patients. At the time of analysis, over 4,060 patients with MBC were included, 49 of which met the requirements for the analysis. Median age was 54. First diagnosis 15%, 15 patients were HER2 negative, 34 were HER2 positive. And this was seen that the 1 year and 2 year PFS were higher for patients who were initially HER2 positive. 1 year PFS of 52% versus 26%, and 2 year PFS of 44% versus 19%. The overall survival curves numbers were too small to make any calculations. So the authors concluded that the median PFS at 1 year and 2 years seemed to be better in patients with HER2 positive diagnosis at initial period, although the result needs to be interpreted with caution because of the small cohort and the retrospective nature. It does justify a prospective research in patients who were initially HER2 negative and then have become HER2 positive as a separate entity. The third abstract is on a new drug which is RC48 ADC. It's an antibody drug conjugate targeting HER2 antibody, and this is in patients with HER2 positive and HER2 low expressing advanced or metastatic breast cancer. This is a pooled analysis of two studies. This was a phase 1 study design looking at two studies, C001 cancer and C003 cancer, in which patients who had advanced breast cancer were used. These are all HER2 positive patients, either IHC3 plus or FISH positive, and also HER2 low expression, that is IHC2 plus, FISH negative, or IHC1 plus in the C003 cancer study. The baseline characteristics of these patients, when we look at HER2 positive versus HER2 low, about 60% patients were HER2 positive. Patients were all with good performance status. About 35% patients had ER or PR positive. 60% patients were having liver metastasis, about 50% having lung metastasis, and almost 50% in the HER2 positive arm having more than 3 prior lines of treatment as compared to 25%. In terms of looking at an overall response rate and progression-free survival, a better overall response rate and PFS was obtained in all patients. These are the waterfall plots, which also show that there is good anti-tumor activity data from RC48 ADC. There was no new safety signal which was detected in terms of treatment-related adverse events, uh, hypostasia, leukopenia, and other GI toxicities. So the new antibody drug conjugate does show consistent efficacy in HER2 positive and HER2 low expressing advanced breast cancer. 2 milligram per kg presented higher efficacy and better safety than other dose levels. And there are these ongoing studies of this drug in combination with lapatinib, capecitabine, or in combination with chemotherapy also undergoing. The fourth abstract was the clinical pathological characteristics of exceptional responders who achieved durable remission beyond 5 years in HER2 positive metastatic breast cancer. We know that anti-HER2 therapies have really improved outcomes for patients with HER2 positive MBC, and yet despite the survival prolongation, many patients still die from the disease. This was a 1,000-patient HER2 database, which was a retrospective review of all patients uh, made prior to December 2015, and DR5 category included those who have never experienced relapse or progression following initial anti-HER2 therapy and those who are alive at 5 years. 245 patients, median survival 38 months, 85 patients, that is 35%, experienced an overall survival of more than 5 years, with 34 patients who are designated as DR5. Median overall survival for DR5 was 117 months, whereas non-DR had median overall survival of 33 months. Median age was similar between both the groups. Higher incidence of visceral disease was present in the non-DR as compared to the DR5, 69 versus 44%. In conclusion, this was a meaningful subset of patients, with 14% patients with advanced HER2 positive MBC achieving prolonged remission beyond 5 years with anti-HER2 therapy. Uh, 25% of those with de novo HER2 positive MBC achieved DR5, and a prospective identification of variables to predict the DR5 could assist in stratification of these patients in whom additional therapy is required. The second last abstract is on the predictive impact of biomarkers on PCR and survival after de-escalated neoadjuvant TDM1 with or without endocrine therapy versus trastuzumab and endocrine therapy in HER2 positive, hormone receptor positive early breast cancer. This is from the WSG ADAPT TP trial. This is the schema in which TDM1 is used. The patients are either randomized to TDM1 alone, TDM1 plus endocrine therapy in a 1:1:1 fashion. A core biopsy is also being done at 12 weeks in case of a clinical non-PACR, and omission of other chemotherapy is allowed in cases with PACR, and trastuzumab is to be completed for 1 year. This is the invasive disease-free survival according to PCR status and additional chemotherapy use, in which we see at 5-year rate no PCR in about 82% chances, PCR plus chemotherapy in about 93, and PCR with no chemotherapy in 92%. We are looking at chemo versus no chemo in patients who have not achieved PCR. So the primary endpoint was PCR. Secondary endpoint included safety, 5-year IDFS, and overall survival. They also looked at the stromal tumor infiltrating lymphocytes, IHC immune markers at baseline, and 3 weekly biopsy samples, the PIK3 kinase mutation, and also a gene expression which was RNA based 800 gene coding set for PAM50 subtypes. There have been significant association between baseline biomarkers and achieving a PCR or IDFS, and there have been multiple different factors in terms of PDL1 or immune cell positivity, invasion, BCL, MCL, tumor infiltrating lymphocytes, which was evaluated. In terms of a PIK3 kinase mutation status, we see here that in all patients, irrespective of the treatment offered, patients who had a mutated PIK3 had a poorer invasive disease-free survival. When we look at TDM1 treated patients, we have a wild-type PIK3 mutation showing 90% 5-year rate, and a mutated showing only 68%. Depending on the molecular subtype, we look at HER2 enriched, luminal A, luminal B, and this is the PAM50 subtype based on the genomic profiling, which is RNA based, and we clearly see the difference in the outcomes as per the subtype. So the conclusions of this were that the baseline tumor immunogenicity is associated with high PCR rates and favorable outcomes for triple positive early breast cancer after de-escalated therapy. PIK3 kinase mutations do correlate with poor outcome even after TDM1, followed by standard chemo trastuzumab in patients who've achieved no pathological CR. Patients with luminal A subtype have the best outcome. Further treatment de-escalation strategies need to be based on PCR rate, outcome, and luminal A subtype. The sixth abstract is from the latest update from the Summit trial, which looks at combining neratinib, fulvestrant, trastuzumab for hormone receptor positive HER2 mutant metastatic breast cancer, and neratinib plus trastuzumab for metastatic triple negative disease, which has HER2 mutant. Now, Summit has been a multi-histology basket study design, which has different types of tumors which are on HER2 mutant, and this HER2 mutation is documented as per the CAP guidelines. Key exclusion criteria is prior treatment with any HER2-directed therapy. This can be a pan-HER2 TKI, either lapatinib, afatinib, dacometinib, or neratinib, and patients with symptomatic or unstable brain metastasis. The evolution of these breast cancer cohorts has happened over a period of time. This has been there since 2018, and now the current cohorts are being reported, which are the hormone receptor positive, HER2 negative MBC, those who have received prior CDK4/6 inhibitors, and this is a non-randomized and a randomized subgroup, and all of them are carrying a HER2 mutant positivity. So here we see that in terms of hormone receptor positive patients, almost 84% patients have received prior fulvestrant, about 50% received prior tamoxifen, and close to 70 to 80% patients receiving prior AIs. Objective response rate is seen in about 46% of patients. Best overall response in terms of median duration of response is about 14 months, and median PFS is about 8.2 months. The efficacy findings for neratinib in the hormone receptor randomized cohorts, We again see an objective response rate of about 28%, 14% CR, 14% PR, and a median PFS of about 6.2 months with a duration of treatment over 5 months. Looking at all the three combined, neratinib, fulvestrant plus trastuzumab, and this shows an objective response rate of 42% with the triple combination and a median PFS of about 7 months with median duration of treatment 6.5. Patients who had received the triple drug combination had greater decreases in tumor size and longer treatment duration than patients not treated with neratinib. Diarrhea is the main side effect. There were some patients who underwent treatment discontinuation. 60% patients had disease progression, 6% had clinical progression, and about 6% had stopped the drug because of diarrhea. So TNBC characters, these are the ones who have been treated with neratinib plus trastuzumab, those who are harboring the HER2 mutation. Objective response rate is again about 33%, median PFS of 6 months. Diarrhea, again, a similar adverse event in this subgroup too. We see here that these waterfall plot does show that there are good responses and sustained responses. Based on the distribution of HER2 mutations and best response, the mutations were distributed throughout the kinase and the transmembrane extracellular domains, and responses were reported in patients with HER2 mutation in any of these domains in all the neratinib containing cohorts. The triple drug combination did show encouraging activity in patients with heavily pretreated hormone receptor positive, HER2 negative, HER2 mutant MBC, those who have even received previous CDK4/6 inhibitors. Objective response rate of 42%, median PFS of 7 months. The neratinib trastuzumab combination did show promising clinical activity in HER2 mutant TNBC, and that led to an objective response rate of about 33% with a median PFS of 6%. Diarrhea was higher than anticipated in the triplet combination, and loperamide prophylaxis and neratinib dose escalation as defined in the control study is very, very important. So this study is continuing to enroll, and they are going to assess whether patients with hormone receptor positive MBC who cross over after progression on fulvestrant or the fulvestrant trastuzumab arm derive any benefit from the triple drug regimen. Thank you.